We begin this remarkable journey with sessions on obstetrics, labor, and fetal medicine. May I please call upon the chairpersons for this session, Dr. Sujata TL and Dr. Shaila. May we have the first speaker for this session, Dr. Uma Ram. She will be talking on the topic Precision Medicine in Perinatology, Balancing Empirical and Individualized Approach. Dr. Umaram is the Director and Lead Consultant in Obstetrics and Gynecology at the Sitapati Clinic and Hospital, Chennai. Welcome, ma'am.
Thank you very much, respected chairpersons. Thank you very much. It's a pleasure to be a part of Advances again. And I look forward to a very interesting conference. I am going to talk on precision medicine because it is where we are today in terms of trying to improve the health of women and individualize care. So in the past, we have actually looked at intuitive medicine and treated people based just on signs and symptoms. Of course, this is something we will continue to do all the time. Today, in the present, we are basing our care and management on evidence-based medicine, based on clinical trial data and what we get from systematic reviews and meta-analysis as the best standards of care. But the future, where we already are making inroads, is with precision medicine so that we can individualize care with the use of algorithms that have been built from the evidence that has been created from trials and studies. So there is a exploding literature in this area, and there is a lot of interest across various areas. Of course, in areas like diabetes, in areas like cancer, already the use of personalized medicine has revolutionized care. In obstetrics and perinatology as well, as the interest grows and as studies happen, you can see, if you just do a PubMed search, you can see that it is somewhere in the last decade that the interest and publications from precision medicine in our specialty has started to increase. So precision medicine is a medical model that proposes a customization of healthcare for the individual, and we can use diagnostics, we can make medical decisions, we can use treatment individualized to that a person instead of a one drug fits all model. Personalized medicine is the use of an individual's information from genetic profiling and clinical information combined to decide which preventive strategy or which clinical model of care is going to give the best outcome when we use them in treatment. So in different aspects, whether it is preterm birth, in the understanding of identifying which woman is going to go into septic shock, the picking up who is at higher risk of preeclampsia or gestational diabetes, and the use of genetic markers and metabolic disease, a lot of work has happened in this area. So we, of course, still a lot of us believe and practice in the traditional approach of using checklists, and we do this based on different things like age, parity, ethnicity, obstetric history, and family history. And I'll start off looking at preeclampsia, and we use these kind of models to say these women are at increased risk of preeclampsia. And of course, if they have had previous early onset disease or they have an antiphospholipid syndrome, they are at highest risk of preeclampsia. This is good, but we know that this does not perform extremely well. And this is more than a decade ago that people have shown that the predictive ability of just risk factor based screening for a 5% false positive rate is only 36%. So it's worse than the toss of a coin, right? And over the and then they still said we could use aspirin. Our understanding of preeclampsia has increased, and we now know that there are different stages, and we have the opportunity of identifying women in the first stage to predict who is likely to get preeclampsia going forward, and not just base it on the development of the actual symptoms of hypertension. And this, of course, was the landmark publication combining maternal factors, mean arterial pressure, and biomarkers to identify women who are at risk of preeclampsia. And today, the FMF model of care is what we use for identifying women who are at high risk of preeclampsia. And subsequently, they have shown that when we give aspirin to these women, we can induce a 60% reduction in the development of preeclampsia, which is significantly better than using the checklist. Of course, there is a huge gap between having a weighted quality of evidence, which we all agree and we quote, but still have a certain reluctance in incorporating it into our clinical practice. And unless we incorporate it into clinical practice, the benefit is not going to be translated to the women. But again, there are ethnic differences, and when you look at data from screening in the Asian populations, we find that our uterine artery PI moms are lower, and the PLGF moms are higher in the South Asian women than in the Caucasian populations, and therefore these adjustments will have to be made. So when we get into adapting a screening protocol, yes, we validate it in different populations, but equally there may need to be a tweaking of a model to make it more appropriate for our own population. When we have used the FMF screening model in our population, this is just a small cohort in our practice, we found that when we used just the NICE alone criteria and did not give those women aspirin unless they also screened positive by the FMF model, none of those women actually developed preeclampsia. So this is, of course, been shown and validated in different studies in different cohorts. But when you see it working in our own population, then you're more confident about not needing to give aspirin because this woman just has a high BMI, even though her preeclampsia risk is lower, or just because her uterine artery PI is higher when her overall PI risk is lower. So we identify and we use a risk of 1 in 100 to determine who gets aspirin. But can we do better? Can we actually identify who is at even higher risk within this cohort? And we all know that women who have preeclampsia are at higher risk of cardiovascular disease going forward. So can we identify those women who develop preeclampsia, how many of them are really going to have problems going forward? Because all of them will not have problems. So when you have a large population, especially in the public sector, where you may not be able to invest follow-up and management of all of them, be having the ability to identify a subgroup of women who are at more risk of cardiovascular disease going forward will actually be extremely helpful. Because in the context of preeclampsia and gestational diabetes, we as obstetricians have the opportunity to identify women and prevent the development of NCDs going forward, which is a very unique position in the healthcare system, which I feel we are not yet actually making the best leverage from for the future of women's health. Now, moving on to fetal growth, we all plot growth based on different charts. We accept that there is a 10% error in the estimation of fetal weight, and we also understand that when you have a very large baby or a very small baby, this error becomes that much more significant. And we find that there are different growth charts. Each one uses a different chart, and when you use a different chart And you can see that the centiles are slightly different, and therefore it is very important that we use charts that are meaningful for our populations. And at the same time, we have to understand that a lot of these charts, whether they are standards or they are growth charts, plot the level, a point of growth of the fetus at that time, do not necessarily help us project or predict what is this baby going to be at 34 weeks or 36 weeks. So that prediction or projection of fetal weight doesn't necessarily happen when we use the routine chart, and there are different growth models that have looked at prediction of weight, and most of the growth models that look to predict weight need at birth need an ultrasound around 36 weeks to be able, or at least some even 1 week before the birth of the baby, to be accurate in terms of prediction, and this is not always practically possible. This is one publication from 2 years ago from Kipros's group, where they said that based on a scan at 36 weeks, for a 10% false positive rate, this is they can predict SGA neonates with a sensitivity of, in 77% and 65% of the time. If they use the 10th centile, and if they use the 3rd centile, then it goes up to 85 and 75%. So I was talking with some colleagues of mine in the Mathematical Science Institute, and they said, let's try if we can do something about predicting birth weight, and they use this formula called the Gompertz formula, which is used routinely for, or which has been used for predicting tumor growth. And interestingly, initially it was developed to look at fetal growth, and it's a number of, little over 700 women, and based on the scan at 12 weeks and around 20 weeks, they work to see if the formula helps predict weight at birth. And this we have published, and this looks like the fetuses. You can predict birth weight, and the prediction of birth weight we validated with a different data set, and we compared it with existing growth models. And the fetuses who did not fit the growth curve actually had a higher incidence of adverse outcomes. And when we compared the growth, the predictive ability of the birth weight with the different growth charts, whether they were intergrowth or Hadlock, it actually showed that this prediction based on the Gompertz model had the mean error was only about 7.8% compared to 10%, and this was without having a scan within 1 week of delivery. Of course, this has to be validated with other data sets, but there is potential to help us identify those babies which we may need to follow much more closely than those who we may not. Moving on to the burden of hyperglycemia, which is very, very high in our part of the world, and the projected increase is actually staggering. You wonder whether there'll be anybody who doesn't have hyperglycemia going forwards. And I feel, waste a lot of time getting focused on how we are going to label a woman as having hyperglycemia, which diagnostic test we are going to use often takes up all the oxygen in the room. And the question is, are we actually doing well in terms of predicting who is going to develop hyperglycemia? Because only if we are able to predict that, will we be able to put in some prevention, whether it is diet or exercise, and in some situations medication, to ensure that that woman does not develop gestational diabetes, just as we are giving aspirin for somebody who is at risk of developing preeclampsia. So this is, of course, just to mention that even though we have the criteria, when we look at how these criteria are being adopted, many people think they're using one criteria, but actually they're using the wrong numbers, and so there's a lot of confusion on who we are labeling in the first place. So the purpose of the STRIDE study, which was done across Kenya and India, of which I was happy to be a part of, was can we risk stratify women in early pregnancy to identify those who are likely to develop gestational diabetes going forward using HbA1c, and then we used a composite risk score based on HbA1c and routinely collected data like BMI, family history, to determine whether they are at risk of developing gestational diabetes. And we developed a population-specific two-threshold screening strategy because A1C alone was not enough to did not have enough ability to rule in and rule out gestational diabetes. So the models that were used was just HbA1c. The second model, which used age, BMI, and family history, and the third one, which used HbA1c along with age, BMI, and family history. And this is the published data from STRIDE India when you used the rule in and rule out. So anybody who had a HbA1c under 4.9 had an 80% sensitivity of not developing gestational diabetes, and the rule in threshold was 5.4. And then when you added the age, BMI, and family history, you actually could avoid nearly 50% of GTTs at 24 to 28 weeks, because you could identify a group of women who were high risk in whom you could actually implement diet and exercise. Now, will that actually reduce GDM? We need a different study to show that it can happen, but at least the potential is there. So does this, and it was, I'm just showing what was there in Kenya and in the UK. They used the same model in another PRIDE cohort, and you can see that here again the thresholds for HbA1c are different in different ethnic groups. Again, emphasizing that ethnicity does make a difference, and it is not, we need to keep that in mind when we are developing models or scores to identify women who are at risk. So we ourselves asked the question, and this is in analysis for publication. Subsequently, we used the STRIDE model in about 5,400 women from across 3 hospitals in South India. After excluding those who had early GDM or overt GDM, we analyzed a little over 5,000 women. And when we applied the model, 91.9% of the true GDMs were predicted at 12 to 13 weeks. 55 of them because they were predicted as the high-risk group, and another 37% were recommended a GTT at 24 to 28 weeks. And only about 8% were predicted at non-GDM. So clearly this offers a pathway to identify. And we're still very, a few steps away from actually personalizing and saying this woman is going to then also have adverse problems. But there are people who have looked at it, and this is the Personal GDM model validated from Australia, with Helena Teed and Shakila Thangaratnam being the main people involved in the study. And they looked at routinely collected data to see whether in women with GDM we can predict who is likely to have adverse risks. Because all women with GDM are not going to have adverse problems, and when we have a burden like 20% of women are having GDM, we put them all in the same bucket. We are going to have a lot of women needing more monitoring, more intervention, which actually burdens the system and burdens the woman as well, because some of them may not be in the group that has adverse problems. So this is a snapshot of the model that is available, which helps predict risk. I spoke about preterm birth, and the QUIP app is readily available, and you can use that to personalize the woman's score of developing preterm birth. I want to say a few words about perinatal depression, because this again is a significant problem in pregnancy, and we have collaborated with a team from NIMHANS, which has looked at some of the samples from women in the STRIDE group and looked to see for biomarkers such as brain-derived neurotrophic factor and beta endorphins. And they have also found that these biomarkers are lower in women who have depression and significantly in women with GDM who have depression. And also, this is a more recent study where they have looked at telomere length and mitochondrial copy numbers and found that in women who have the risk of who develop GDM and have depression, the telomere length is shorter, and they have, potential to identify these women with a possibility for intervention. So what goes into precision medicine is, you look at gene expression, they are looking at proteomics, which is protein in a biosample, they're looking at metabolomics, which is metabolic profile, lipidomics, which is lipid characteristics, and epigenomics, which is looking at epigenetic modifications to GNA, and microbiomics, which is characterizing the microbiomes that are present in the woman. Of course, the challenges are that cost and equity. All these tests are expensive, and to make them available to the public, it is going to be a few more years, but it has the potential. The physicians need to upscale ourselves to understand how to interpret this test, and then about information and privacy. So I conclude, because we are moving away from the era where one size fits all to where we can make to measure and actually influence the health of the woman, not just in her pregnancy, but in the future health as well. Thank you very much for the opportunity.